Well, hello everyone. Welcome back again. I have another interesting case for you. This case was sent to me by one of our attendings here, Dana Sajid. Dana was one of our early fellows at the program here at MGH, then went out west. We realized, big mistake, we got to get him back, so we finally did. We got him back earlier this year, so Dana's here to join us and explain his case. So Dana, thank you for coming in and talking to us.
Yeah, thanks for having me, Scott.
Yeah, so tell us about this case.
Well, we were working in acute care one night, and we got a notification call from the medics that they were bringing in a pregnant lady who was approximately 35 weeks or so by dates, who was in respiratory distress and hypoxic.
Yeah, and blue is what I was told, I think.
And blue.
Yeah, so when I was working that day too, and I was kind of interested to see what was going on, this is what I walk into. And so PICU was there, OB was there, all these other people, I have no idea where they came from, were looking and see what was going on.
Yeah, well, we'd given a heads up call to the OB folks and to the newborn folks to come down because, again, we just got a call that a 35-week pregnant lady was in extremis.
Yeah.
And so we wanted all hands on deck.
Yeah, so you're the attendant, you have everyone and their mother here to see what's going on. And so what did you think? Tell us about what would she look like and all her vital signs and everything.
So EMS comes in with a woman who's slightly obese,
Yeah.
blue, absolutely blue in the face, and obviously in respiratory distress, struggling to breathe. They were trying to bag her, and she was profoundly hypoxic, and she was very tachycardic as well. And our thought process, top of our differential at this point, was PE in
course.
this pregnant hypoxic tachycardic woman.
Yeah, what else could it be, huh?
Right.
So, TPA, don't even do it. Let's just give it, see what happens.
So we had called to get the TPA ready because we just, again, top of our diagnostic differential list was pulmonary embolism.
Yeah.
So we were getting the TPA ready. We, of course, the OB team was there and the neonatal team was there, and they were just getting ready to do their thing as well.
But they were ready for you to push it.
Everyone was on board.
Yeah.
I mean, everyone's thought process was this pregnant lady who is hypoxic, blue, and tachycardic is probably having a PE.
Yeah. So just give it and then see what happens, or.
Well, that was the thought process at first. But of course, we did some other bedside studies. Being the good ultrasound attending that I am, we already had the machine in the room and at the ready to go for two reasons. One, she was pregnant. We wanted to check the viability of the fetus. The OB people were very interested in that. And two, any patient with undifferentiated shock and undifferentiated extremis, this is a great tool to have at the bedside.
Definitely. And so this was her ultrasound that you recorded. Can you go through this with us?
Yeah, absolutely. So first we shot a picture in the parasternal long axis view of the heart. And to be honest with you, I was expecting to see a very large dilated right ventricle pushing the left ventricle out of the way, something along those lines. Instead, what we saw was a left ventricle that isn't squeezing very well all around, and the mitral valve leaflet that's not moving very well either, suggesting to us that this woman had a pretty poor ejection fraction.
Yeah, and that's the biggest thing from this that you can see. This is the mitral valve right here. This is the septum. And if someone was extremely tachycardic from a PE, you would expect her EF to be almost 80%. And here, it's definitely diminished since it's not going too far. And then we have another view here.
And in the parasternal short axis view, we saw the same thing. Pretty much poor global effort in the left ventricle there.
Yeah, and then I have your four-chamber view here.
In the four-chamber view, again, we were expecting to see a big, massively dilated right ventricle coming into the left ventricle, causing compromise because of this large PE, but that wasn't there at all. Instead, what we saw was a big, poorly moving left ventricle and a right ventricle that's working really hard.
Yeah, it's impressive. I mean, that's not diminished in any way. There doesn't seem to be any sign of enlarged right-sided pressures as the RV free wall is moving pretty good. So for you guys watching this, I have a couple images for you. This is Dana's case right here on the right, and this is a normal parasternal long view, and you can see that the mitral valve is hitting the septum or close to it on this, whereas here it doesn't even come close. The parasternal short here, you have nice equally contraction at all parts of the LV, and then here you can tell when you compare the two that it's much more diminished. And then finally your four-chamber view, you can see how from based on the apex down here and the septum and left-sided over here, how it's coming together nicely. And on this 4-chamber view, not as much. And so I know in addition to this, you guys looked at the legs, and we didn't have that here for everyone. But
right. We, again, because thrombus was pretty high on our list to begin with, we looked at the femoral veins and quickly at the popliteals to see if there was any clot, and we didn't see anything on quick 2-point compression studies.
And then here you guys can see that there are all these artifacts coming from the pleural line. And so did this then maybe push you to do a lung ultrasound as well?
Absolutely, absolutely. Seeing this echo made us think that there was something else going on other than PE, obviously. And when we looked at the lungs, we saw what a diffuse B-line pattern in the lung fields.
Yeah, and though not labeled, this is the right apex. And so if there were at MGH or some other conventions, you can label this as zone 1. But here, for you guys, it is the right apex. And this is the left apices. And again, the same pattern. You see these artifacts that are called B-lines that are basically from the pleural line all the way down. And they are indeed artifacts, but they are, this is what happens when you do have pulmonary edema.
Right. So we saw this diffuse B-line pattern suggesting pulmonary edema in a lady with a poorly contracting left ventricle. So that changed our thought process quite a bit.
Yeah, so not a PE, but more cardiomyopathy.
Right.
Yeah, crazy. So can you, I mean, if you had given this lady TPA, who knows what would have happened?
Who knows what the outcome would have been.
So we followed up this case, and after admitted to the ICU, the very next day had an emergent C-section. The baby was then taken to the NICU, and at the time of this recording, both mom and baby are home and well. So very fascinating case, and just illustrates how by doing a point-of-care bedside ultrasound totally changed the management and really made a difference in not just one life, but both of their lives. So, as always, please send us any emails, any cases that you may have to mghedus@gmail.com. And Dana, thank you for joining us and sharing this case with us.
Scott, thank you for having me.
Cool. Thanks, everyone.